Hello, good day, and welcome to today's webinar, Overcoming COVID-19 Vaccine Payment Challenges. At this time, all participants are in a listen-only mode. Please note this call is being recorded. Please enter your questions into the Q&A panel located at the bottom of your screen. The attendee chat is disabled for this event. It is now my pleasure to turn the call over to Colleen Fry from CMS. Please go ahead.
Thank you. Hello, everyone, and welcome to Overcoming COVID-19 Payment Challenges. I'm Colleen Fry, Director in the Division of Community and Population Health, Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. I want to thank the nursing homes and pharmacies attending today and commend you for your continued efforts to vaccinate nursing home residents and staff against COVID-19, despite the payment challenges you may be facing. I would also like to thank my CMS colleague, Will Harris, staff from Telligent and HSAG, and Chad Warts from the American Society of Consultant Pharmacists for participating in today's event. It is now my pleasure to introduce my colleagues, Sabrina Chaktura, Nurse Consultant for the Division for Quality Improvement and Innovation Models Testing in the Centers for Clinical Standards and Quality at CMS, and Dr. Melissa Briggs-Hagen, a medical epidemiologist at the Centers for Disease Control and Prevention and a captain in the U.S. Public Health Service. Sabrina is certified in infection control and epidemiology and served extensively on the COVID-19 response team, including COVID-19 vaccine uptake and mass vaccine clinic coordination. She will join Dr. Hagen at the end of today's events to co-facilitate our Q&A discussion. Dr. Hagen has led the Applied Epidemiologic Studies team in the COVID and other respiratory viruses division at the CDC for the last 3 years and is currently serving as the acting chief medical officer in the CDC's Immunization Services division. Dr. Hagen, the floor is now yours.
Great. Good afternoon. It's a privilege to be joining you today on behalf of the CDC and to be working alongside our federal partners, CMS and the QIA and QIOs to talk about this important topic and learn from our speakers about successful strategies for overcoming payment challenges in the long-term care setting. As we know, nursing home residents are at risk for becoming infected with and experiencing severe complications from respiratory viruses like SARS-CoV-2, influenza, and RSV. The combination of older age, comorbidities, and living in a long-term care setting puts these residents at higher risk for infection, severe disease, and death. We continue to see the burden of respiratory diseases highest among older adults and nursing home residents. For this past 2023 to 2024 respiratory virus season, between September 4th and May 5th, we received reports of greater than 360,000 COVID-19 cases and over 20,000 hospitalizations from COVID-19 among long-term care residents. Because it's voluntary, only about a quarter of facilities report on influenza and RSV, but even there, we received reports of over 10,000 influenza cases and over 4,000 RSV cases among long-term care residents between October 2023 and May 2024. Protecting nursing home residents against severe outcomes through increasing vaccination coverage continues to be a high priority. However, by the end of March 2024, 43% of nursing home residents and just 11% of nursing home staff were up to date with COVID-19 vaccinations. And among the 18% of facilities that reported RSV vaccination data, just 20% of nursing home residents had received the RSV vaccine. Flu vaccination coverage is a little bit better. Among the 19% of facilities that reported flu vaccination data, 73% of nursing home residents had received the flu vaccine. However, overall, this leaves significant room for improvement. And we know that this is really a multi-sectoral effort. We appreciate all the work you all are doing to serve and protect this population by increasing vaccination coverage in nursing homes. We hope to continue to find successful strategies to work through challenges to vaccination and increase coverage even more in the upcoming 2024 to 2025 season. To this end, we're excited to hear from our excellent lineup of speakers today and learn about strategies to overcome billing and payment obstacles in nursing homes. I will now hand over to our first speaker, Will Harris. Next slide. Will Harris is a senior advisor in the administrator's office at the Centers for Medicare and Medicaid Services, where he works on pandemic and emergency responses and the agency's oversight and coverage priorities with the Center for Clinical Standards and Quality, as well as the Center for Program Integrity. Will moved to Washington from DC from his home state of Louisiana to work in the United States Senate, before joining CMS in 2015 in the Office of Legislation. He joined the Office of the Administrator upon Administrator Brooks LaSure's confirmation, and he holds a Bachelor of Arts degree in Political Science as well as Philosophy from Louisiana State University and a JD and Graduate Diploma in Comparative Law from LSU's Paul M. Herbert Law Center. Will, the floor is yours.
Thank you very much, Melissa, and thanks for being here with us today. Thanks to everybody for being here with us. You can advance the slide so I don't have to look at myself. Thank you. Thank you for being with us to talk about this really important topic. I want to pass along my thanks to you from the administrator on how hard all of you are working to make sure that people in long-term care settings are vaccinated against COVID-19 and other respiratory threats this coming season now and in this upcoming season. We know that making sure that people in those kind of congregate settings who often have multiple comorbidities are sometimes at highest risk for complications from COVID-19 flu and RSV. So we know how critical it is to get this right and to make sure that we're doing everything we can to remove hurdles that that you may be running into, and we want to know about those and hear from you about what we can do to make that easier. Next slide, please. So I'm here today just to talk about resources that we've made available over the last year. We've put out a new fact sheet for skilled nursing facilities, for nursing homes, that talks about how common questions that people have for billing vaccines under Medicare Part A. It lays out answers to common questions that folks have. And you can go to the next slide. That's just a picture of the top of the fact sheet. This lays out the information that you need to know about what is covered and how. This is what's available on the fact sheet. So I'll make sure to have that link in the chat for you here soon, right after I'm done talking, to make sure you have a direct link to this to have all of this information. But the long and short of it is that it depends on which product for exactly how it is covered and then paid for. For RSV vaccines, but thanks to the Inflation Reduction Act, those are covered without cost sharing under Medicare Part D. So for anybody who has Part D, they're covered without cost sharing. And then these bullets here, again, that you can go read, I'm not going to read it to you, explain how to go about billing for that and how it's covered for folks. And thank you for that reminder. These slides will also be available afterwards, so you can refer to this. Next slide, please. For flu, pneumonia, and COVID-19, those are actually listed in our Medicare statute as vaccines that are covered under Medicare Part B, as in boy, without cost sharing. So this lays out, and again, this is on that fact sheet. And we have more information available online that you can get linked to from this slide as well about how exactly to bill for that with the codes and everything that you need for various kinds of residents. The most important change here is what happened a couple months after the PHE ended. And that said, during the PHE, when the public health emergency was active, you may have been used to being able to have your third parties who bill, who come and do vaccine clinics or anything with your residents. They were able to bill Medicare directly. That's no longer possible outside of the PHE because the PHE ended. We don't have the legal ability to allow that to occur anymore. So one change that you've probably noticed, and that's very important to make sure you work out, is that that third party, that independent potentially vaccinator who comes on site, now needs to bill the nursing home. The nursing home gets paid for that service in the bundle here, as explained in the fact sheet. So that's an important change that has happened after the PHE. Again, something that is in statute that has to be part of that bundle payment, and that we can't allow those independent vaccinators to bill directly to Medicare, although that was something we allowed the flexibility to do during the PHE. So that's an important change. You can go to the next slide. That was the highlights of what I was going to talk about today. I know that several of you have had questions or sent in questions ahead of time. I want to make sure we all have everybody speak here who is going to speak, and we can then get to some of those questions afterward. And it's my pleasure now to turn it over to Megan Myers, who's the clinical pharmacy specialist at Telligen. who is going to speak next. Thanks, Megan.
Thank you, Will, for the introduction. I'm excited to be here today to share more about how our partnership with community pharmacies assisted our nursing homes with some of their barriers to get vaccines to their residents. Next slide, please. Telegen is the Quinn QIO for Colorado, Illinois, Iowa, and Oklahoma. So this project was implemented across those 4 states. Next slide. Our objectives today are to discuss barriers among long-term care facilities related specifically to vaccine access, administration, and billing. So we know that there are other barriers in play, such as vaccine hesitancy, but this project was implemented to specifically target those 3 barriers. I'll describe our partnership with the Community Pharmacy Enhanced Service Network to offer vaccine clinics, which focused on the respiratory vaccines that Will just outlined. So that included influenza, pneumonia, RSV, and the COVID-19 vaccines. But other vaccines were also available upon request, such as the shingles and the tetanus vaccines were probably the most popular add-ons to these clinics. Then I'll review the process for how we connected pharmacies to nursing homes. Next slide, please. So for some background, we reached out to over 1,000 nursing homes in our region just to listen and learn about the barriers they're facing providing immunizations to their residents. We discovered that there were access and supply barriers, especially in our rural areas and areas that had a high social vulnerability index, which is an indicator of health inequities. And then billing and staffing shortages were very large and universal barriers. With those staffing shortages, it's very real. The American Healthcare Association did a state of the sector survey, and 7 out of 10 nursing homes that responded to the survey said that they still are not up to their pre-pandemic levels in terms of employees. So there's a very large staffing shortage that they're trying to overcome. And then for billing challenges, that can be anything from not understanding the process of how to bill to not understanding how to navigate rejections. That also kind of goes hand in hand with the staffing shortage, because with the staff turnover, institutional knowledge has been lost. And then with that staffing shortage, the new staff members don't have time to figure out the process to bill and navigate those shortages. And then for those who do know how to do the process, they're still facing time challenges, and providing vaccination services, a very time-intensive activity when we're talking about everything from identifying the residents and what vaccines they need, to ordering and managing inventory and storage, administration, billing. And then for nursing homes, they actually have to document potentially up to 3 times. So in their state immunization registry, in their electronic medical record, and then for the COVID vaccine into the NHSN platform. Next slide. As Will lined up, the nursing homes should be able to bill Medicare Part B for all levels of stay, but some of them report issues with COVID-19 vaccine billing. And I think that goes back to just that time to figure out the correct process of billing the commercial product that's now available. They cannot bill for the RSV or shingles vaccines because those are only covered by Medicare Part D plans. Next slide. This led us to investigate a partnership with the Community Pharmacy Enhanced Service Network. So this network is a group of small, regional, and independent pharmacies that provide enhanced pharmacy services to their patients. And this included the full adult vaccine services for those routine vaccinations. They covered our 4 states. They're highly involved in their communities, and they were willing to mobilize a response quickly. Next slide. Now, for the pharmacies, we knew it would not be a perfect solution. One of the pros is that they're able to bill both the Medicare Part B and the Medicare Part D and Advantage plans for most residents, but there were those stipulations that they can no longer bill residents on a Medicare Part A stay or on hospice. So if they do the administration, as we'll outline, they would need to bill the facility and have the facility bill for those doses. But if the facility doesn't know how to bill for that, that can be a barrier. And then they also must have to be in network for billing a Medicare Part D or Advantage plan. So if a resident's Part D plan is not in network with the pharmacy, then they're not able to provide a covered RSV dose for those patients. And these pharmacies did not have, were not networked for the Bridge Access Program. So if there were uninsured residents needing the COVID-19 vaccine doses, then we were referring out to local public health to obtain those doses for those residents. Next slide. For our process, nursing homes would fill out a request to Telegen. They found out about our clinics through 2 different avenues. So first, we spent a lot of time with our team doing one-to-one outreach to nursing homes that had low, up-to-date COVID-19 vaccine rates. And then we also worked with our community partners to promote the clinic opportunity, which included departments of public health and nursing home associations in our state. We then reviewed and sent the information to CPESN to get matched with a pharmacy. Once matched, we provided education just around best practices for clinic planning, which includes sharing the guide that Will outlined and offering support for the NHSN reporting. We encouraged the nursing homes to collect consent form and insurance information to send them to the pharmacy prior to the clinic so that they could verify coverage and there wouldn't be any surprises around uncovered doses. This is definitely a rate limiting step that's a little bit time intensive for the nursing homes, but even with this step, adding the pharmacy as a partner definitely provided a decreasing that staff burden because the pharmacy took care of all the vaccines, the supplies, administering the doses, billing the doses, and putting those doses into the state immunization registry. So after the clinic, the nursing homes only needed to document electronic medical record and then the NHSN for those COVID doses. We also provided a travel stipend to the pharmacies, which were very critical to reach our rural areas and those smaller 20 to 30 bed facilities where the pharmacies might not have been able to afford to send a team out for the vaccine reimbursement alone. So I think that was a big driver for the success of some of our clinics. After the clinics, the pharmacies reported their results back to CPESN and they send it to us. Next slide. For our results, these numbers are from the NHSN database. We had a mean increase in resident COVID-19 doses by 16.6%. And then we also looked at the subgroup in those who were in areas with a high social vulnerability index, and they actually had a greater impact with an increase in 28.8%. So we were pleased to see that providing that travel stipend was a successful strategy to reach those areas that were potentially more vulnerable to having a barrier be vaccine access. And then we did not see an improvement in the staff rate, which I think demonstrated to us that their primary barrier is vaccine hesitancy because the convenience of bringing the vaccine to the facility really did not impact the staff rate. Next slide. So these are our current numbers. We've had 60 clinics so far. We don't have all the numbers back, but for those we do, we've had just over 2,300 respiratory vaccines administered. So we were very happy to see that those results was a successful strategy in getting the vaccines to the residents. We know that there were still barriers with billing and still gaps where maybe the resident was not in network to the pharmacy or the nursing home wasn't sure how to bill those Part A stays and hospice stays. And I think that was just a really important lesson learned with this project, that even when we put these two entities together, we were still not capable of billing all the vaccines for all the residents that are recommended to them by the CDC's Advisory Committee on Immunizations Practices. So I think there's still further strategies that need to be explored to get everyone the coverage that they need, but this definitely had an impact that would not have occurred if the nursing homes hadn't partnered with the community pharmacies. That is what I have. So thank you so much for the opportunity to present. And I'm pleased to announce our next speaker who has done some amazing work in his region. Eli DeLille serves as the Associate Executive Director of Prevention Infection with the Health Services Advisory Group. He has more than 20 years of experience in the healthcare industry with expertise in quality improvement, analysis and implementation of performance improvement, patient safety initiatives, and direct patient care. Eli earned a master's degree in nursing from Marshall University. He's certified in infection control and is a fellow with the Association for Professionals in Infection Control and Epidemiology. Eli, you have the floor.
Thanks, Megan. I appreciate the introduction. as well as the opportunity to be here today and share the journey that HSAG has had in our 2 target states of California and Arizona as we improve vaccination rates in long-term care. Next slide. I think that Colleen, Dr. Hagan, as well as Will did a great job. Like, we all know that long-term care facilities are at extreme risk of future surges of respiratory illness. It's a congregate setting. It often houses our most vulnerable or immune-compromised population. Many of us lost family, friends, loved ones. And I think that the way that HSAG's team looks at this is that every vaccine that we help administer through this program is potentially a life saved. And we know that those vaccines offer our best ability to reduce severe illness, hospitalizations, and even death. Next slide. Unfortunately, the reality of it is you could have the best billing practices in the country, but if your uptake, your resistance to vaccination is really strong, we're not going to hit the targets that we want to hit, which of course is 100% vaccination across the board. So what HSAG has done is we've actually created a multi-pronged approach where we're tying together data support with education, training to combat that hesitancy so that when we do schedule a clinic, we can vaccinate as many folks as possible during that visit. Next slide. And these are our numbers. So we were fortunate early on to be able to partner with a pharmacy in Los Angeles, California. And then since that initial partnership, we've actually expanded to 2 additional pharmacies that we work with, which they cover both of our states of California as well as Arizona, which is a huge geographic region. But we're doing, I think, better now than we ever have before, especially with our most recent partnership with a pharmacy that's actually able to cover both states as well. When we partner with a pharmacy, they actually help with the registry review to make sure that we're giving the appropriate vaccines to our residents. And they also do that chart-specific review that helps them identify if they're following the best practice recommendations on the vaccines that need to be administered. And when we partner a nursing home with a pharmacy, they're not just helping with those record reviews, they're not just administering vaccines, they're helping with the billing for the residents and the staff, which we know is key to the success, especially with how many strained resources the nursing homes have right now. And these numbers are a little bit old, I apologize, but they're about a month old or so. So in our target states, we've had actually over 200 education sessions. We've done over 700 vaccine clinics, 13,500 COVID-19 vaccines, over 3,000 pneumonia vaccines, and over 1,000 flu vaccines. So close to 18,000 vaccines have been administered in those 700 clinics just in the 6 months that we've really been targeting this work. Next slide. And you can see that we're not just making an impact at the local level, we're actually seeing numbers move at the state level. I mentioned before that it took us a little while to get partnerships in Arizona, so you'll see that their numbers are a little bit behind where California is. But now that we have a pharmacy partner that's able to cover the entire state, we expect these numbers to move very, very quickly. And just to give you an idea of just what the impact of our program has been, 30% of the total nursing homes in California are working with us, and approximately 28% of the total nursing homes in Arizona are working with us. And we see that number literally increase on a daily basis. Next slide. So we're very fortunate at HSAG that we have a team that includes experts in long-term care. I'm an infection preventionist. We have NHSN experts. We have former directors of nursing, as well as administrators from nursing homes. And we sat as a team, after talking to multiple nursing homes, and really identified that the biggest burden was just time, right? They can navigate the billing challenges, but they have to have the resources in order to dedicate the time and attention to that. Additionally, it's not just the billing that they have to navigate. I mentioned before about, the NHSN reporting. Many of our infection preventionists have turned over 4 or 5, 6 different times since the onset of the pandemic. And with this turnover, it's very difficult to keep an idea of exactly what needs to be reported and to whom. And the other thing is once again, uptake is important. We can have a vaccine clinic, but if we don't have people signing up for the vaccine, we're almost failed before we can even begin. So, once again, we focused on data. So utilizing NHSN to know who we needed to target, and that's the National Health Safety Network. With each nursing home has to report their COVID-19 data, vaccination information for staff as well as residents. And then we use that data to drive on-site or virtual education. So we can actually go to your nursing home, meet with your staff, meet with your residents, and meet with their family. Once again, the on-site vaccine support, which we know is crucial, and then assistance with that vaccine billing. Next slide. And when we talk about the on-site or virtual education, we really believe at HSAG that this has been the key to our success and that almost 18,000 vaccines administered. So what we've discovered talking to our partners is everyone is burnt out, of course, but what they're burnt out about is the control measures. So those of us that do infection prevention and control, like control often happens after the infection has already entered the building. So that's where we see the increased testing, the masking, the isolation, which strains already really short resources. So if we can focus on prevention and stop that infection from ever gaining traction within the facility, it's going to make everyone's life better. It's going to improve the residents' quality of life as well as the staff. So what we try to do in every single request that comes to us is it a reporting issue? Is it an education issue, or are they ready right now to have a clinic? We often do one-on-one sessions with our residents, family members, and then having an opportunity to do a listening session with the staff has been so important to engage that frontline group and give them a mechanism to be heard and to just voice their concerns. We see a lot of misinformation out there, and they want to talk. They just want to be heard. And we often see going into a nursing home that had 0 residents or even staff that are willing to get a vaccine, we walk out with multiple consents being signed. Next slide. So this is a story of a large nursing home in Southern California, and it kind of shows how we pull all those disparate pieces together to make sure that if we have a clinic, we have a successful clinic. So we utilized NHSN data. We identified that this facility just wasn't performing well. Their vaccination rates for the residents as well as their staff was low. So we reached out to them. We had a very crucial conversation and said, what can we do to help? And the administrator said, realistically, we don't even know where to begin. The facility is so large, there's so much vaccine fatigue and hesitancy. So our team member, April Ramirez, who's amazing, she actually sat down in person with the leadership team and said, how can we move you towards best practices as it relates to your vaccine program? That ended up resulting in 3 education sessions for residents and staff, and it covered multiple shifts and multiple days. April, she was kind of burning the midnight oil. She was coming in late to catch the night shift and coming in early to catch the oncoming shift. And it actually included where there was so many residents over 40 that they were not their own decision makers, and the infection preventionists didn't feel comfortable talking to those family members about, the importance of vaccination. April sat with that person, made those calls, and when we left that day, we had over 400 vaccine consents and now have a pending vaccine clinic for that facility, where if we would have just immediately connected them with a clinic, who knows if we would have got 20 or 10 or even 5. So with that concludes my portion of the presentation. We'll go to the next slide. And I'm going to turn it over to Chad Wars, who is the CEO of the American Society of Consultant Pharmacists. Chad, the floor is yours.
Thank you, and I'm very honored to be here today to talk about vaccine success factors in long-term care. As mentioned, I'm Chad Wers. I'm the Chief Executive for the American Society of Consultant Pharmacists. Our pharmacists and pharmacies are long-term care pharmacies. Across the country, they service skilled nursing facilities and assisted living facilities and older adults. And certainly, as we've all learned through the COVID pandemic, this population has been the one that bore the brunt of the burden, certainly the most vulnerable, and the importance and significance of good vaccine practices in long-term care settings is paramount for all of the infectious diseases that we deal with, but certainly as we hone our systems for future pandemics and for future deployments of vaccines. So I'm thrilled to be here. Next slide. And I have spent quite a bit of time in the long-term care space before coming to ASCP. I had a consulting pharmacist practice, and I also practiced for a large regional independent pharmacy in the Midwest. Again, just really want to thank everybody for their continued vigilance and work in the long-term care space. I know everybody worked very hard during the COVID pandemic to get people vaccinated, and we continue to work hard and on the behalf of the very vulnerable patients that we service. Next slide. So just to get into it, there's some key points I really want to emphasize, because one of the things that does exist in our current system is flexibility. There is a lot of confusion around how things are billed and where things are billed and who can bill and who can vaccinate. But ultimately, if you take a step back, there's quite a bit of flexibility in implementing strategies that improve vaccination rates in skilled nursing facilities. So we'll start with the beginning. Essentially, we make a decision for either our existing residents or new admissions on what the care plan of their vaccines is going to be during our stay in the nursing facility. Generally, that is determined on admission by a team of people, nursing as well as pharmacy, that are doing admission reviews. And one way to amplify or increase our surveillance of somebody's vaccine history is to use the medication reconciliation process on admission to identify gaps in vaccine therapy for the patients that are coming in. So regardless of how we are approaching vaccine, whether it's the seasonal vaccines and we're preparing for a vaccine clinic, or we're taking a new admission or a new individual into our nursing facility, we determine their vaccine history, we get that into the patient record and onto the care plan, and we move forward with how do we arrange and implement vaccine strategies. Next slide. There's flexibility also on the billing side. So we'll start with Medicare Part A. These are our rehabilitation patients in nursing facilities. If we look at how they can be billed, there's really two ways that they can be billed. The primary way is that the nursing facility bills for the vaccine and the administration for COVID, flu, and pneumococcal vaccine to their Medicare Part B plan for the patient. These three vaccines are exempt from the Medicare Part A consolidated reimbursement, and they can be billed by the nursing facility. One of the things that's not well known is that through the pandemic, there was flexibility in having pharmacies and nursing facilities co-contract for vaccine services. So if you're in a situation where the pharmacy is coming in and doing vaccine clinics for the Part D or the custodial residents in the nursing facility, they could also perform the vaccine services for patients in their Part A stay. They just wouldn't be able to bill for it. The nursing home would bill for it and reimburse the pharmacy for the administration services. That flexibility also exists on the other side, where in the Part D space for the custodial residents of the nursing facility, the pharmacy can bill for the vaccines and for the administration of those vaccines, and they can work with the nursing facility on the reimbursement for that last mile or that actual administration of that vaccine. So that's one flexibility that exists that I think is not well known and really offers some opportunity in terms of flexibility for people that are trying to implement good vaccine procedures and processes. Why it's flexible and why I think it's important is because it gives the facility and the pharmacy an opportunity to determine what do they do well and how do they best feel like vaccine services can be provided to their residents of their nursing facilities. If it's a nursing home that's well-staffed and has a good process for identifying and administering vaccines to their patient population, then the pharmacy can certainly support that on the Part D side for those vaccines that are billed to Part D plans. If it's a facility that relies on the pharmacy to come in and provide vaccine services, then it provides them the flexibility to allow the pharmacies to come in to do that, either using their own personnel or contracting with the nursing home, again, for that last mile of that nurse providing that vaccine. One of the benefits to that is also the documentation into the state immunization services systems. So the state IAS systems, generally, long-term care pharmacies are connected to those systems. Those systems can provide insight into someone's vaccine history. They also provide, again, that full circle responsibility for vaccination, which is documenting that this person was given their particular vaccine in the nursing facility. So if it is a patient that's just in the nursing home on a rehabilitation stay and they leave and go back home, and they come back later for another rehab stay or for another reason, we'll have the ability to look them up in the state system and identify their vaccine history. So there's quite a bit of flexibility across Part A and Part D from a billing perspective, as well as from an administration perspective. And that's one thing I really want to make clear to everybody, is that those flexibilities exist. And it really comes down to the long-term care pharmacy and the nursing home determining what is the best path for them, what is the best way that they can provide the most access to their residents. And it can be a combination of some of those practices. Next slide. Again, looking at the non-Part A, these are the Part D billed vaccinations. On those patients, they can also be Part A patients and Part D patients. So I'll explain that. But on the custodial side of the nursing home or the long stay side of the nursing home, generally vaccines that are not COVID, influenza, or pneumococcal are reimbursed through Medicare Part D. Nursing homes don't have mechanisms to bill Medicare Part D, but pharmacies do. So generally, pharmacies will bill for that vaccine product, be reimbursed, send that product to the nursing facility, and the nurses will administer those vaccines. Well, there is the opportunity, again, for the pharmacy to bill those vaccines and their administration of those vaccines and share that administration fee with the nursing facility, again, in an effort to provide good fair reimbursement and to incentivize the process of full circle vaccination. So ordering, delivering, administering, and then reporting that information not only to the nursing home systems, but also to the state immunization systems so that we have that good full circle documentation. That also exists for Part A residents outside of COVID, flu, and pneumococcal vaccines. So if it's a vaccine that is paid for by Medicare Part D, and we're talking about a patient in their Medicare Part A stay, those vaccines can be billed to that patient's Medicare Part D plan. So these would be things like the shingles vaccine or the RSV vaccine that we may identify as required in a patient that's residing in their Part A stay of their nursing home stay. That can be billed by the pharmacy to the Part D plan for both the product and the administration. And again, that administration could then be performed by the pharmacy to that individual in Part A, or can be contracted with a third party or with the nursing facility to provide that administration to that patient in Part A. Now, there's a lot in those two slides that I shared with you, and it's confusing, but hopefully having it described and asking questions about it to both pharmacies and nursing facilities can create that understanding of the flexibility that does exist in the system. Ultimately, it's about getting people vaccinated when they're ready to be vaccinated and when they're able to be vaccinated. And we don't want to have any closed doors or any opportunities to say, well, we can't provide that vaccine because you're in your Part A stay, or we can't provide that vaccine because you're outside of your Part A stay, or you're in your Part D stay. The idea is to provide systems that allow for people to get the vaccine when they're ready to get the vaccine, when they've been counseled and educated on the importance of those vaccines. And again, in our population of vulnerable individuals that reside in nursing facilities, there's no more important aspect of their care than getting them the vaccines that they need, particularly against the infections that we know are so detrimental to them. Influenza, COVID certainly, and the emergence of RSV. Next slide. Some other keys to success that I think are important as we consider the long-term care space or the skilled nursing home space is not only knowing their vaccine history, which we talked about. We have mechanisms that we're already doing, medication admission reviews, looking at their medications as a whole, including vaccinations in that. But there's also other things that we can do. We know that we're required to offer vaccines. The language that we use and the confidence that we use with patients and caregivers about vaccines is important. It's important for facilities to say, in our facility, this is how we approach vaccinations. We give vaccinations. We give the flu vaccine if we find that somebody hasn't had it, or that they're unsure if they've had it this flu season. That language piece of it is important, and it's important in your approach to, again, the resident or the caregivers of the resident. If we can exude confidence, if we can state this is our medical practice in our nursing facility, it goes a long way toward having people feel comfortable about getting their vaccinations. Again, we don't want anybody to face a closed door. We don't want anybody to be not as informed as they could be about receiving their vaccines, particularly in this population of vulnerable older adults. If you look at the keys to success here, you can also see that there are templates for contracting for vaccine administration. Again, these are two-way contracts between the pharmacy and the nursing facility that allow each entity to perform vaccine services where it's appropriate and where it's needed. So again, if we're aware that nursing homes have to bill Medicare Part B for residents in their Medicare Part A stay for COVID, influenza, and pneumococcal vaccine, pharmacies can perform the function. It just has to be billed by the nursing facility. And this contract allows for the pharmacies and the pharmacy personnel to perform that function. And then that also includes the reverse on the Part D side. The pharmacies are billing Part D for the product. They can bill for administration, and they can contract with the nurses in the nursing facility to provide that administration, which includes reporting back to the pharmacy for good documentation into the state immunization systems for your particular state. So I can't emphasize that enough, because those are a couple factors in vaccine services in long-term care that are not well known, and that may be even new to you as you listen to this presentation, but they do provide the flexibility to help us improve our processes. And as we approach this next flu season, this next fall season of infectious diseases, it's going to be important that we have good plans and good implementation strategies, because ultimately we're dealing with multiple vaccines, both the flu vaccine, the COVID-19 vaccine, and potentially the RSV vaccine. Next slide. Again, we talked about reporting to states' IAS system. During COVID, all the pharmacies that worked in long-term care became connected to their state's IAS system. That allows them to document when people are receiving vaccines. That is critically important as we try to create history for patients that we can access later to determine if they have or haven't had one of their recommended vaccines. That allows us to care plan for patients as they enter our environments, so that we're providing them the best protection against infectious disease. We know that cost of vaccines is in a different place than it was pre-COVID. Pre-COVID, generally there was one type of flu vaccine. It was relatively inexpensive. Post-COVID, we now are talking about high dose or adjuvanted flu vaccine for people over the age of 65. We're talking about a COVID-19 vaccine. Those vaccines run in the hundreds of dollars. We're talking about RSV vaccine also running in the hundreds of dollars. That becomes a challenge for nursing homes to manage, for pharmacies to manage. So looking at the cost of vaccines, applying what is our best effort to have inventory for vaccines so that we have the availability to give it to our patients, not risking wasting vaccine by letting it expire or having too much or not storing it properly. So facilities and nursing home pharmacies working together to try to figure out what the best strategies are is paramount to running a good vaccine service. Co-administrations of vaccines is also an issue. As mentioned, in the fall season, we'll be looking at potentially 3 vaccines. If any of the other vaccines that are recommended are not on the patient's history and are required, those are also things to consider. So knowing that per ACIP guidelines, 2 or more inactivated vaccines can be co-administered or administered at any interval is important from a planning perspective. How do we have people feel comfortable, and how do we get them vaccinated with a good plan of care for each individual as we assess their histories and we determine what the best foot forward is for them as it relates to the vaccines that they need. I think that's my last slide. So again, I think the things that are important are some of the things that I think might be new or not as well known to individuals. It's the contracting opportunity between pharmacy and nursing home for both the administration of the vaccine and the provision of the vaccine. It's using the existing resources around medication admission and the medication admission process to determine history so that we can care plan. And it's really determining a good vaccine process so that you can exude confidence to your new residents or to the caregivers of those residents on how practice occurs from a vaccine perspective at your particular facility, and giving them the comfort that you are on top of it, you are care planning it, And you're going to make sure that those residents are protected against infectious disease in your facility. So I'll turn it over. I think we're headed to a discussion period. I look forward to the discussion period and talking about keys to success.
We have our other presenters on camera. There we go. Great, just wanted to get our panelists up. All right, so moving into the discussion. I would just want to highlight that there's been a lot of questions put into the Q&A, so thank you all for engaging and putting those questions in. And about half of them have been answered via text. So if you put something into the question box, please do check there and see if it's been answered. And we have a few formal questions, but we'll try to get to the ones that we can from that box now as well. Should I just dive into the first question? Is there anybody has anything to add? Okay, so our first question that was received in advance: have any expectations or guidance been developed for Medicare Advantage plans or private pay insurance related to immunizations? Will or Eli, either of you want to take first stab at this?
I'll start out by saying that Medicare Advantage plans must cover at least what traditional Medicare fee-for-service covers. That includes the COVID-19 vaccines as well as flu, pneumonia, and those vaccines. So Medicare Advantage plans must cover those. I answered one question in the chat about this and said if they are not absolutely appropriate to submit a complaint about that, we definitely want to know if that's not occurring. So thank you. And yes, we've that toward the beginning of the vaccine rollout certainly pushed out lots and lots of information to the plans to tell them how important it was to get this working quickly.
And I'll just add to what Will said. I put 2 links in the chat to everyone, but there's legislation out there that requires that insurance plans pay for ACIP recommended vaccines. So if you find somebody that's denying that, and it is a recommended vaccine, then you definitely should use these resources. One was the Inflation Reduction Act, and the other was all the way from 2010 with the ACA.
And I should amend and correct one of my statements to say that if it's a Medicare Advantage plan, definitely submit that complaint to Medicare. I put that link on how to do that in the Q&A. If it's for a marketplace plan or a private insurance plan, it would be appropriate to submit that complaint to your state's Department of Insurance. Thank you.
Wonderful. So I think we can go to the next question. Is there any specific guidance on billing for dual eligible, an example, Medicare, Medicaid residents?
So Will and I talked about this yesterday, and basically Medicare should be the payer, the first payer, and Medicaid should be the payer of last resort. So we did hear some examples where Medicare is potentially denying a claim. You just want to make sure that the ACIP recommendations are being followed. As long as they're being followed, then Medicare should cover that, and it should not go to Medicaid to need to cover that. So you just want to make sure you're very clear on what those recommendations are and that you're following them.
Thanks.
And if you want, I can give an example of that. So, let's say that you received a COVID vaccine and it wasn't documented in the registry at the state level, and you immediately gave an additional dose of a COVID vaccine, or a flu vaccine is an even better example. Well, that second dose of flu vaccine wasn't considered necessary, so that claim may be denied. So it's really important that you know the history of vaccines so that you're not trying to bill for something that's not appropriate.
Great, thanks, Eli. Did anybody want to add anything
Yep.
to that? Okay. All right, so we'll go to the third question. Are nursing home residents and staff over 65 who do not have Medicare Parts B and or D responsible for covering the cost of vaccinations? So have you all come across this? Megan, do you want to start if you've come across it?
Sure. In my experience working in community pharmacy and going on site for clinics, I found that most insurance providers still offer coverage for the vaccines at no cost sharing. I would occasionally see copayments or rejections, but it was pretty rare at this point. And so we would try to bill whatever insurance they do have active. If it was for like the veterans population, it was really important to find a location that's also contracted with TRICARE, since that has a limited network.
And I know it, okay. So Will or Eli, do you have anything to add to that?
I was going to add that it's important to be aware of what your local and state health departments have to offer. Like, we have mobile vaccine clinics in our state. There's all kinds of resources out there for uninsured individuals. And if you're not aware of them, then they're being underutilized. The other thing is, and it's going away in August, unfortunately, but the CDC has their program, the Bridge program, that helps with uninsured. And it's been a tremendous resource to those that are uninsured or underinsured.
I would also add that this is one of the challenges, is trying to determine all of this before that dose is administered, because if it's discovered that the provider can't bill that patient's contracted insurance after the fact, then they might be responsible for covering the cost of vaccines. So we want to avoid that as much as possible.
Yeah, the importance of doing the groundwork. All right, over to Sabrina for the next question and the next slide as well. Thanks.
Is there an example of a large nursing home that serves a high number of short-term rehab patients that has had success billing for COVID and pneumococcal vaccines for their Part A residents?
So we work with 3 partner pharmacies across our state, and I kind of gauge their responses. And to be honest with you, there's not a huge number of success stories. But where we see the most success is where you partner with a pharmacy or you have somebody to bounce questions off of. It's an extremely complex market. I would say that, one of the reasons why we've been so successful is those strong pharmacy partnerships. So if you're a nursing home that's struggling with this, just being able to navigate it, look for pharmacies in your area that would be interested in helping you with vaccines, with supply issues, as well as helping you navigate some of the billing, the complex billing environment. Of course, they can't bill on your behalf, but they're often very knowledgeable. And I know, Megan, this is something that you've actually done as a community pharmacist as well.
Yes, and I would say that in general, it's a big challenge in the short-term rehab space to vaccinate it by the time you have your process to identify the need, get the vaccine in. They could be out the door already. And then billing challenges, the rejections may come a month or 2 later and you don't know. And so in general, it's just a challenging space to provide vaccinations. But one strategy to keep in mind is just remembering the importance of that vaccine hesitancy and of doing the education, screening, and referral, and making sure you have a strong partner. So if you are having challenges billing, one other strategy we've seen the short-term rehab space use is just really providing that education while they're there, and then having direction on where to go in the community to receive that vaccine once they're done with their rehab.
All right, our last question that was shared in advance is, what are the common reasons for delays in reimbursement? Don't know, Will, if you want to speak to this or if others want to start with what they're experiencing.
I definitely want to know what other people are hearing too. If you're having problems, you should definitely go directly to your MAC. Like, that should always be your first step for any problems with Medicare billing, is to connect with your Medicare administrative contractor first. If you're having problems with that, then certainly escalate it. Happy to talk about, how to do that. But the MAC is always your best sort of first stop for any kind of billing or payment issues. Definitely want to hear what other people have experienced too.
I would echo that and just making sure that all the billing codes are set up correctly to begin with, because a lot of the delays in reimbursement has to do with having to rebill them due to incorrect billing codes.
And to that end,
We have a couple.
because
Oh,
I've seen a
sorry.
couple of questions at the Q&A about it. I'm going to put a link to our website here that has all the codes for ingredient codes and administration set up there. Sorry, Eli.
Oh, no, that's fine. So once again, I polled our pharmacies, and the primary reason for rejection at this point or delays is the inaccurate registry information. So if our pharmacy, well, a lot of nursing home residents are not great historians, right? So if that isn't documented clearly somewhere to reference, then the pharmacy has no idea that a vaccine was administered. So if we go in and we give a flu vaccine in the nursing home and it's not documented in the registry and it's not easy to find for the pharmacy, they're using that registry as their source of truth. So I would say if you're a nursing home out there, like the importance of making sure that all vaccines are documented in those registries, whatever your state specific one, is imperative, because if you're over vaccinating, then there's a very good chance that that unnecessary vaccine is going to be potentially rejected. The other issue is if hospice is not clearly documented within that resident's record and it's billed as a regular resident and they find out that it's a hospice one, the pharmacy could be following the incorrect approach for that particular situation. So those are probably the two primary reasons why we see delays right now.
Wonderful. Thank you so much to our presenters and panelists for going over these discussion questions with us. Next slide, please. So thank you all for joining us. We truly appreciate you being here. We are aware that there were quite a few questions in the chat that we were not able to answer, some related to hospice or non-nursing home facilities. So we will see what we can do to review some of those questions, get them to the right people, and see if we can get some feedback to everyone. So thank you so much. I hope you all have a great day.